नहीं मिला सर कोई स्क्रीन की।
हाँ
कर रहा है सर, कर रहा है, दोबारा
ठीक है। So guys, just give me 1 second. I think I just came out from this ask me anything session for the form filling, so probably there are some technical glitches. We will sort that out in a minute and then I will start the session. So guys, 1 second. I think I just came from so just guys hold on for a minute. I think there are some technical issues. My iPad capture is not streaming as of now. Okay, so guys, I guess the screen is visible to all of you. So we will start with our continued revision of the medicine, and in this session we will be addressing endocrine disorders. I'll give you a quick overview of what we are going to cover. We will cover the pituitary disorders, we will cover the basic diseases that are important from endocrine, and then we will take up some PYQs. Adrenal gland will be addressed by my surgery colleague once he starts with the surgery revision. Okay, so we will start first with the pituitary disorders. Like we are all familiar, pituitary gland has two parts, right? We have an anterior lobe of the pituitary gland, or what we call as anterior pituitary gland or adenohypophysis, right? Anterior pituitary lobe and posterior. Posterior is also called as neurohypophysis and anterior is called as adenohypophysis, right? This we call as adenohypophysis. So basically anterior pituitary gland is a true gland and the posterior pituitary gland is basically an extension of the hypothalamus. Okay, now anterior pituitary gland is concerned with secretion of 6 hormones. What are those? Number 1, growth hormone. Number 2, prolactin. Growth hormone and prolactin are secreted by similar cells, so we call them as acidophil cells, right? These are the hormones secreted by the acidophil cells. And the remaining hormones from the anterior pituitary, that is ACTH, TSH and gonadotropins, that is your FSH and LH. These are secreted by your basophil cells. Basophil cells. Now why am I talking about it? Because this can also be an MCQ. They might ask you like, okay, which of this is secreted by an acidophil cell or which of this is secreted by a basophil cell. Primarily a physiology question, but you should know. Okay. Now when it comes to posterior pituitary, it secretes 2 hormones. Number 1, ADH or vasopressin, which is concerned with regulation of your plasma osmolality, and number 2, oxytocin, which is concerned with milk ejection reflex and your parturition or labor, right? Okay, now let us look at the disorders of the anterior pituitary. Now what are the disorders of the anterior pituitary? First let us take growth hormone, right? Let us address one by one. We will start with the growth hormone. Okay, so that will be my first hormone. Now growth hormone is concerned with what its function is to stimulate tissue production. What type of tissue? It primarily stimulates protein synthesis and growth of height vertically as long as epiphyses are not fused. Now if there is a growth hormone deficiency, what will happen? If you develop deficiency before the fusion of epiphyses, that means growth hormone's job is to increase your height vertically. If there is deficiency, you will not be able to attain your final good height, right? So if deficiency happen before the fusion of epiphyses, it leads to what is called as pituitary dwarfism, right? We call it as pituitary dwarfism. So you will have a very short height in comparison to the age matched, race and ethnicity matched peers, because there is no growth hormone, so no vertical growth possible. Okay. Now what if the growth hormone deficiency happens after the fusion of epiphysis? If it happens after the fusion of epiphysis, in that case we have to remember that already you have achieved your full adult height, right? So this leads to mainly vague symptoms, right? What symptoms we can lead to? We in that case call it as adult growth hormone deficiency, and generally this is associated with obesity and fatigue, because growth hormone is required for protein synthesis. Once you have low growth hormone, sufficient protein synthesis won't be there, so you will lose muscle, gain more fat. Whatever you eat becomes fat rather than becoming muscle. Okay. Now if I get excess growth hormone, more than the required amount of growth hormone, if that happens before my epiphyses are fused, in that case my final height will be way more than what is expected, right? So in that case we will call it as pituitary gigantism. Pituitary gigantism, right? Like for example, 𝐒𝐿, the great wrestler 𝐒𝐿 is an example for pituitary gigantism, where he had growth hormone excess even before the fusion of epiphysis. That's why his height is quite tall. Now on the other hand, if I develop growth hormone excess after my epiphyses are fused, then my height is fixed. My height can't increase anymore because the epiphyses are fused. But there are still certain tissues which can continue to grow. What are those? Your acral parts. Acral means what? Distal parts of the body, hands and feet. They can continue to grow, right? Enlargement of hands and feet, right? Your facial bones like maxilla, then the forehead and mandible can grow. They will continue to grow. Soft tissues will grow, right? So when this growth happens, we call that condition as acromegaly, right? Why are we calling it as acromegaly? Because here the growth is of acral parts. Acral means hands and feet. Clear? Okay. Now for the exam sake, what is important for us? From the adult medicine, you need to know the clinical features and diagnostic evaluation of acromegaly and the management, and similarly you need to know little bit about adult growth hormone deficiency. So first let me start with acromegaly, right? As the name says, it means increase in the size of acral parts, which is nothing but your hands and feet. Okay. When it happens, when you have a chronically elevated growth hormone, chronic excess growth hormone. See, normally after some strenuous physical exercise, gymming, running, right, or a good sleep or taking a protein rich meal, your growth hormone level shoots up, but it will come back to its baseline. But persistently, chronically, if your growth hormone level is elevated, right, after fusion of epiphysis, it will lead to acromegaly. Okay. Now we should definitely know the causes. The most common cause for the growth hormone excess acromegaly is a growth hormone producing pituitary tumor. Growth hormone producing pituitary tumor. Now one point you have to remember here is that majority of the growth hormone producing pituitary tumors are, most cases are due to macroadenoma. Most cases are due to macroadenoma. Then comes the question, what do I mean by macroadenoma, right? So please remember, make a small note. Microadenoma means the tumor size is less than 1 centimeter. The maximum diameter wise is less than 1 centimeter, right? When you say macroadenoma, that means it is more than 1 centimeter but less than 4 centimeter. And when you say giant adenoma, giant means when it is more than 4 centimeter. In that case, we will call it as giant adenoma. Okay. So micro is less than 1 centimeter, macro is 1 to 4 centimeter, giant is more than 4 centimeter. So majority of the patients of acromegaly are due to macroadenoma. Means by the time you recognize that they have acromegaly, they have a tumor more than 1 centimeter in size. Okay, that is not the only cause. There are other causes, right? There can be ectopic growth hormone production. There may be other tumors like bronchial carcinoid, pancreatic neuroendocrine tumors who can produce growth hormone. That can be another cause. But what is most common cause? Pituitary tumor. Okay. Now growth hormone production can be stimulated by a hypothalamic hormone called as growth hormone releasing hormone. If that is in high quantity, that can also lead to acromegaly, right? That high quantity can come from either a tumor of hypothalamus or other tumors. Ectopic tumors may also be secreting excess growth hormone. Okay. Now if I have excess growth hormone after the fusion of epiphysis, I am developing acromegaly, but as a clinician, how will I recognize it? What are the clinical features, right? So height of the individual may be normal because already there is fusion of epiphysis, but other growable tissues will grow, right? And that will lead to recognizable clinical features. Number one, when you look at this image, what do you notice? There is a frontal bossing, right? There is frontal bossing. Why there is frontal bossing? Because under the influence of growth hormone, the frontal bone is grown. Its growth does not stop. All your axial skeletal bones, right? Your humerus, femur, tibia, they will stop the growth once the epiphysis is fused, but the frontal bone will continue to grow. That's why we can see frontal bossing. The second thing, when you look closely in this image, right, what do you notice? That there is a prominent jaw, right? Prominent jaw. Why there is a prominent jaw? Because the even mandible continues to grow, right? What do we call this as? We call it as prognathism. Prognathism. That is one more finding that we can see in patients with acromegaly. Okay. Now, when you look at the jaw, especially the maxillary hyperplasia will also happen, but your mandible grows much more. So when mandible grows, what will happen to the space between the teeth? Because mandible is growing, there will be space created between your lower incisors, right? So when you look at that, there is increased spacing between lower incisors, right? Between lower incisors. All these are potential image based questions. Okay. Next, when you look at this image, this is image of a hand of a person who is normal, who has normal growth hormone, and on the right you have hand of a patient with acromegaly, right? You can clearly notice that the hand is enlarged, right? This is actually what we call as acromegaly, enlargement of acral parts. Now here in the question, often they mention, they won't directly tell you that the hand is increased. Generally they will mention that patient now complains that the ring is now not fitting easily to him, right? Increasing ring size. Another thing that they can mention is that if there is a lower limb, right, increase in the feet size, they might also mention as increasing shoe size. Normally once you are adult, your shoe size is fixed, it doesn't increase anymore, but here if the feet is growing, their shoe size will increase. Okay. Now if I take an X-ray of this patient's hand, particularly when I concentrate on the fingers, what I notice here is normally the distal phalanx should look somewhat like this, right? But instead of that, I can see a small spur at the outer lining. Okay, so now it looks like a spade, and this is what we call as spade phalanx sign. One more important image based question. This is what we call as spade phalanx sign. This question has been asked in the previous FMGE. Where do you see spade phalanx sign? We see that in patients with acromegaly, right? Why do we call it a spade? Because it looks like a spade. It looks like a spade. Why that is happening? Because there is excess bony growth. Why the bone is growing? Because of the influence of growth hormone. This is excess bony growth that is happening. Okay. Now apart from that, there will also be increase in the soft tissue growth. Okay. How do I recognize the soft tissue growth? I can look at the heel pad thickness. So when you take an X-ray of the feet in a lateral view, this is the soft tissue of your heel, right? We call it as heel pad. So we will have increased heel pad thickness. The normal heel pad thickness should be less than 21 millimeters. Here it will be more than 21 millimeters, saying that you have an increased growth of soft tissue. Okay. Now I will show you one more image. Look at the image and tell me what is this. Taken from the skin of a person with growth hormone excess. Some of us may be having these changes, right? We call them as skin tags or acrocordons. These are called as skin tags or acrocordons. Skin tags or acrocordons. Why are they seen? Why skin tags are happening in these patients? Because under the influence of growth hormone, even the skin is growing. That excess growth is creating these tags or acrocordons, right? Now we have to remember one important point here. The skin tags correlates with risk of colon cancer. Risk of colon cancer. So does that mean acromegaly is associated with increased risk of colon cancer? Absolutely yes. Patients with acromegaly carry high risk of colon cancer because there is growth hormone which will stimulate the growth of tumors also, right? And if you have higher the number of skin tags, higher is the risk of developing colon cancers. Okay, so these are the basic clinical features that these patients will present with. Most of the FMGE questions, if they are talking about acromegaly, primarily they talk about a patient presenting with increasing ring size and increasing shoe size. So if you see this in any question, first thing that should come to your mind is, okay, this is a question of acromegaly. Okay, so on clinical grounds, if I have suspected that patient is having acromegaly, how do I proceed with the diagnosis? First thing, what we know is growth hormone is produced by the pituitary gland, and growth hormone does not directly act on the tissues to cause growth. Growth hormone acts on the liver. It stimulates the liver to produce a substance called as insulin-like growth factor 1, right? This will act on your bones and muscles. This will act on the bones and muscles to increase the growth. This is the basic mechanism of action of the growth hormone. Okay, so now for the screening test, we generally do not depend on growth hormone estimation. The reason for that is growth hormone levels keep going up and down. If you sleep, growth hormone increases. Okay, if you take a protein rich meal, growth hormone increases. If you take a carbohydrate rich meal, growth hormone goes down. So obviously we cannot rely on one growth hormone reading. Instead, what we do is we will look at the insulin-like growth factor levels. So IGF-1 levels are considered as the screening test of choice. IGF-1 levels. Okay. So if there is increased IGF-1 level, it means you can suspect a case of acromegaly. If the IGF-1 levels are normal, it is less likely to be a case of acromegaly, right? So in case of acromegaly, IGF-1 levels will be increased. Okay, so any case based on the clinical grounds, like all these symptoms, if you are suspecting that it is a case of acromegaly, you will go ahead and do the IGF-1 levels as the screening test. And if IGF-1 levels are elevated, you have to go ahead with a confirmatory test. Okay, now what is the confirmatory test that we will be doing? You have to remember one point here. In endocrinology, whenever we talk about a hormone excess state, we do tests which are primarily meant for suppressing the hormone. See, what we try to do is, okay, if you have growth, a high hormone, any hormone which is very high, then I will give you a substance which is known to suppress the hormone levels. After giving the substance, also your hormone levels are high, means that you have a problem with that hormone. It is really high. If after giving the substance, your hormone level goes down, it means you don't have excess. Simple, right? On the other hand, if you have a state where hormone deficiency is there, then we do provocative test. So what do we do in provocative test? I will give you a substance which is supposed to stimulate hormone production. For example, growth hormone, right? For growth hormone, hypoglycemia is a potent stimulus for growth hormone secretion. So if I subject you to hypoglycemia by giving insulin or something, and if with that your growth hormone level increases, that means you have a normal growth hormone. But even after hypoglycemia, if your growth hormone doesn't increase, that means you have deficiency, right? So simple thing. In case of excess states, suppression test. We'll try to see if I can suppress the high levels. In case of deficiency, stimulation test. I will give a substance to stimulate that hormone production and see if it comes back to normal or not. Okay. So here acromegaly means growth hormone excess. So I have to do a suppression test, and I have already told you that carbohydrate rich meal suppresses growth hormone, protein rich meal increases, right? So here I have to suppress. So I will use glucose. So what I will do is I will give 75 grams of oral glucose. Remember, in medicine 75 grams of glucose is standard when we do oral glucose tolerance test, right? For diabetes diagnosis or GDM diagnosis, we give the 75 itself. Okay. So after giving 75 grams of oral glucose, what do I expect to happen to the growth hormone levels? Come down significantly, right? So I will monitor the growth hormone levels for 2 hours at every 15 minutes interval, serial monitoring. And in this 2-hour period, I will measure the lowest growth hormone value. That is the suppressed value, right? So if the lowest value is less than 0.4 micrograms per liter, that means it is well suppressed. In that case, patient doesn't have acromegaly. It is normal. On the other hand, even with the oral glucose loading, if the growth hormone levels remain more than 0.4 micrograms per liter, that means it is not suppressible. That means it's really high. And in that case, I will make the diagnosis of acromegaly. So 2 questions here. What is the screening test? It is the insulin-like growth factor levels. Second question, what is the confirmatory test? It is the glucose suppression test. And if acromegaly, what will happen after the glucose suppression test? Growth hormone will still remain high. If it is a normal patient, after glucose suppression, growth hormone level will come down. Simple. Okay. Now, once we have diagnosed the case as acromegaly, how will we manage? First question, what is the most common cause for acromegaly? The most common cause for acromegaly is a growth hormone secreting pituitary adenoma. That too, it is going to be a macroadenoma, right? Now, you tell me what should be the treatment of choice for acromegaly? Obviously, there is a tumor, right? And unfortunately, this tumor cannot be easily managed with medical management. So, we have to go ahead with surgery. So, for a treatment of choice, it will be transphenoidal pituitary adenoma resection. Okay. Now, if the tumor is really large or you're not able to resect it completely, right? Medical management can be considered as an adjunctive. Medical management is an add-on or an adjunctive treatment and not a mainstay of treatment. The treatment of choice will still remain surgical removal of the growth hormone producing tumor. It is adjunctive, right? What drugs can be used? The drugs that we use are mainly somatostatin analogs. Somatostatin analogs. This is again an MCQ. What is the medical management? Generally we use somatostatin analogs. Why? Because somatostatin inhibits growth hormone secretion, right? Remember here, somato is addressing growth hormone secreting cells. The growth hormone secreting cells are called as somatotroph cells. Okay, we are inhibiting that. That's why it's called as somatostatin, the substance. And analogs are derived. What are the analogs? We can use octreotide. You may be familiar with this drug, octreotide. Okay. Second, you also have drugs like lanreotide. Then you have drugs like pasireotide. So these can be used as medical management for your acromegaly. Clear? So simple multiple MCQs. Most of the questions are going to be clinical recognition of acromegaly. So any patient who has seen growth of hands and feet, think of acromegaly. Last FMGE there was an image based question giving you a similar image and asking you what is the diagnosis. Simple straightforward question. Okay. Other than that, spade phalanx sign has been asked multiple times. Increasing heel pad thickness is also asked in NEET PGS multiple times. Okay. Then they've asked what is the screening test, IGF-1 level, confirmatory test, glucose suppression, treatment of choice, transphenoidal, removal of the pituitary tumor. Okay. Now coming to the adult growth hormone deficiency. See, if the growth hormone deficiency happens before the fusion of epiphysis, then patient will not reach his final height. In that case, we will call it as pituitary dwarfism. But if growth hormone deficiency happens in adults, right, what are the clinical features? Patient has already reached his height, right? Now the body will start recomposing. In what form? Because growth hormone is required for the maintenance and synthesis of muscle. Now you don't have growth hormone, so muscle mass will start decreasing. But if you're eating well, then what will happen to that extra calories? It will become fat, right? So clinical features wise, these patients will present with obesity, right? Decreased muscle mass and increased adiposity, right? Now what symptoms it will lead to? It will lead to increased fatigue, and when as an adult, if you're chronically fatigued, you will have a impaired quality of life. Very difficult to diagnose in clinical scenarios because patients have impaired quality of life. If a 45-year-old comes to me with these symptoms, I will say, okay, you're working in an office, you have a sedentary lifestyle, you're eating junk food, and that's why you have all these problems, right? Instead of evaluating. That's why I tell you, adult growth hormone deficiency is very difficult to recognize condition. Until and unless you have a high index of suspicion, you miss it, right? In the exam, they won't ask you about, okay, symptom wise you identify whether this is growth hormone deficiency or not. All they will ask you is what is the investigation of choice for diagnosis. I've already told you, whenever you have a hormone excess, we do suppressing test. Whenever you have hormone deficiency, we do stimulating or provocative test, right? So the provocative test that we do is, it is called as insulin tolerance test. Insulin tolerance test. Okay. Now why are we doing this? Because hypoglycemia is a potent stimulus or provocation for growth hormone release. So what I will do is, I will give insulin to the patient. Okay. We will give insulin to the point that the blood glucose level drops below 40 milligrams per deciliter. Now that is a significant hypoglycemia. After that, in a normal physiological state, the growth hormone levels will start increasing because of hypoglycemia. Okay, so we will see what is the peak growth hormone level, highest growth hormone level that we will recognize after hypoglycemia. Okay, if that is more than 5 micrograms per liter, that means it is clearly a case of normal individual. He doesn't have growth hormone deficiency. But if it is less than 3 microgram, that means there is growth hormone deficiency, right? Is that clear? That means there is growth hormone deficiency. Okay, now once that I have confirmed that there is growth hormone deficiency, how would I manage the case? So we have to recognize that for the management of these cases, we have to only treatment is growth hormone replacement, right? So management of GH deficiency is growth hormone replacement. So these patients will require subcutaneous injections of growth hormone. Okay, anyway, growth hormone is also abused by the gym goers and fitness enthusiasts. Be aware about it. Okay, so that's about our growth hormone. Excess, acromegaly, deficiency, adult growth hormone deficiency presenting as obesity and fatigue. For the acromegaly, investigation of choice. For screening, IGF-1 levels. For the confirmation, your glucose suppression test. For the growth hormone deficiency, there is no screening test. There is only a confirmatory test, and that is insulin tolerance test or insulin induced hypoglycemia test. Okay. If there is acromegaly, most commonly it is caused by a pituitary tumor, so operate it through a transsphenoidal route. If there is growth hormone deficiency, most commonly it is idiopathic, so we don't try to look for the cause, rather we will replace the growth hormone. Okay. Now the next hormone that we are taking up is prolactin. Okay. Now prolactin excess is well known. Prolactin deficiency is known to cause only one symptom, that is your lactation failure. In a male, prolactin deficiency never gets recognized because they are not symptomatic of it. In females, it leads to failure of lactation. If the patient is non-pregnant, you will never recognize that they have prolactin deficiency. So all questions, all clinical cases will be related to increased prolactin levels, hyperprolactinemia. Okay. Now in terms of causes for hyperprolactinemia, there are several. Right? It can be physiological, pharmacological or pathological. There are few key points that we need to remember. Physiological, we know pregnancy is one, right? Then nursing is one. Then if there is a nipple stimulation by the suckling of baby, it can also lead to increase in prolactin levels. And there is an MCQ that you may get. The most potent stimulus for prolactin secretion is nipple stimulation, right? It is the strongest stimulus, most potent stimulus for prolactin secretion. That is an MCQ that has been asked already, right? What is it? Stimulation of the nipple. Okay. Exercise, stress, sleep, seizures, all of them will also cause excess prolactin. Okay. Drug wise, dopamine antagonists are well known to cause hyperprolactinemia, right? Can anybody tell me why dopamine antagonists are going to cause hyperprolactinemia? The reason is, for prolactin secretion, there is no stimulatory hormone. Most importantly, prolactin is under the inhibitory control of dopamine. So your hypothalamus continuously produces dopamine, and this dopamine will have a inhibit or a brake on the pituitary for the prolactin secretion. Okay. So if I inhibit dopamine using dopamine antagonist, then I am removing the inhibition and prolactin secretion will increase, right? So all the drugs which are dopamine antagonists will increase the prolactin secretion. Okay. Now coming to the pathological causes. Pituitary tumors are the most common cause. Pituitary tumors are the most common cause, pathological cause for the hyperprolactinemia. Okay. Other than that, if you have hypothyroidism, I want you to remember some of these causes specifically. So one of them is hypothyroidism, then chronic renal failure as well as liver failure. So if you have liver failure, renal failure or hypothyroidism, you can have hyperprolactinemia apart from a pituitary tumor. And last but not the least, this is also a repeatedly asked MCQ. That is, what will happen if I cut the pituitary stalk section? Which hormone will increase? So if I cut the pituitary stalk, all other hormones, they will decrease, but your prolactin will increase. Why? Because all other hormones like growth hormone, right, TSH, ACTH, all of them are under stimulatory control of hypothalamus. Hypothalamus will secrete growth hormone, releasing hormone that will stimulate the pituitary gland to release growth hormone. If I cut the stack, hypothalamic substance will not reach pituitary, so growth hormone production will come down. Similarly, there is something called as corticotropin releasing hormone or CRH, which will come from the hypothalamus, stimulate the pituitary to produce the ACTH. So if I cut the stack, CRH won't reach the pituitary, so pituitary won't produce ACTH. But hypothalamus secretes dopamine, which controls or suppresses the prolactin release. If I cut the stack, the dopamine doesn't reach the pituitary, and thus I will lose the control on prolactin, and prolactin secretion will go on and on. So that is why if a pituitary stalk is cut, which hormone increases? It is prolactin. Okay, clear? Now if I have hyperprolactinemia, what clinical features I can experience, right? So the clinical features are going to be different in males and females. Okay, so in case of females, excess prolactin will lead to galactorrhea, right? Milk production even when the patient is not pregnant or nursing. Galactorrhea and amenorrhea. Obviously, a male is less likely to have galactorrhea because his breasts are not primed for milk production. So male will generally present with, right, he will present with loss of libido, means loss of interest in sexual activities. So that is why males are diagnosed late in comparison to females. Diagnosed late, because if a male is having issues with his sexual function, he is unlikely to seek medical care in the early stages. Only when he develops symptoms of prolactin producing tumor like your bitemporal hemianopia, he will come to the hospital. But a female, the moment she notices that galactorrhea is there, there is something abnormal, and they will seek medical attention. Okay, so once you have recognized that patient has got hyperprolactinemia, right, how would you treat? Obviously we have to treat the underlying cause. Treat underlying cause, right? If the underlying cause is a drug which is responsible for it, withdraw the drug, right? If there is a dopamine agonist, stop it. Okay, if there is a treatable physiological cause, treat it. Apart from that, how can I suppress the growth hormone, the prolactin production? Simple. Prolactin is under the inhibitory control of dopamine. So if I enhance dopamine action, prolactin will come down. How can I enhance dopamine action? By giving dopamine agonist, right? Dopamine agonists. What are the examples for dopamine agonists? I can think of using drugs like cabergoline and bromocriptine. Okay. Now between these two, I want you to remember few points. Cabergoline is long acting and it is preferred in most cases, right? It is long acting and it is preferred in most cases. But bromocriptine, relatively short acting, multiple dose of administration required. But because it has long standing efficacy and safety established in case of pregnancy, this is a preferred agent in pregnancy. So if you have hyperprolactinemia and you need to treat it during pregnancy, if you have to choose a drug, then it will be bromocriptine. For all other cases, preferably we use cabergoline because it is long acting. Okay. Now coming to one of the cause for hyperprolactinemia, that is prolactinoma, right? Okay. So what is prolactinoma? It is a prolactin secreting pituitary tumor originating in the anterior pituitary gland. Few important MCQ point. It is the most common anterior pituitary hormone secreting tumor, right? So overall among the pituitary tumors, what is the most common cause? It is the prolactinoma, which is the most common cause. The second point you have to remember is that the size of the prolactinoma correlates with the prolactin levels. Higher the prolactin levels, it is likely to be a bigger prolactin secreting tumors. And remember here, prolactin levels greater than 200, right, indicate a tumor as a cause. Indicate a tumor as a cause. See, we have known other physiological and drugs, right? Drugs and all generally won't raise the prolactin levels to more than 200. So if I have a prolactin, normal is less than 25. If I have 50, 60, 100, 125, it can be because of drug or a physiological stress, exercise and all. But if I see 200 plus, it is almost always because of a tumor. Okay. Now the tumor can be of varying size. I have told you size correlates with the tumor. So we have to remember that when we call it as microadenoma, right? Microadenoma means less than 1 centimeter. Macroadenoma means greater than 1 centimeter but less than 4 centimeter. And when it is more than 4 centimeter, we will call it as giant adenoma. Okay, now we know the basics of the prolactinoma. Let us look at the clinical features. Clinical features of prolactinoma can be divided into two groups. Those that are due to excess prolactin, which we have already learned, right? In a female, the female is likely to present with galactorrhea, and amenorrhea. A male is likely to present with decrease in interest for sexual activity, what we call as loss of libido. Okay. Now, apart from these hyperprolactinemia symptoms, we have a tumor there in the pituitary. This may be suppressing or compressing the adjacent structures, and that mass effect will also lead to some of the symptoms, right? What are the symptoms of mass effect? Basically, number one, I can see headache. Okay. Second, this tumor, if you remember the anatomy of the pituitary gland, you might remember that just above the pituitary gland, right, you have this optic chiasm. Somewhere here is the optic chiasm. So if there is a tumor of the anterior pituitary, it is most likely to grow upwards. It can't easily grow laterally because there is a sphenoid bone, right? Below also there is a bone, so it generally goes towards superior and compresses the optic chiasm. So if there is a compression of optic chiasm, it will lead to visual field defects, right? What do we describe it as? Bitemporal hemianopia. Bitemporal hemianopia. So patients may present with headache, bitemporal hemianopia, galactorrhea, amenorrhea, or loss of libido. Okay. So if you have these features, we have to suspect that it could be a case of prolactinoma. Now, how do I establish the diagnosis that there is a tumor in the pituitary gland? I have to do a imaging, and the imaging modality of choice will be MRI. Because your CT scan cannot recognize such small tumors, right? Most of these tumors are microadenomas. Growth hormone secreting tumors are commonly macro. Prolactin secreting tumors are generally micro, right? So in that case, it is less than 1 centimeter and only an MRI can recognize it. Okay. Now, once I have recognized on the MRI that there is a prolactinoma, how do I treat it? Do I have a different treatment for micro, macro and giant adenomas? The answer is no. Fortunately, the prolactin secreting tumors show excellent response to drugs. Like if we give them dopamine agonist, dopamine not only inhibits prolactin secretion, but it will also inhibit the replication of prolactin producing cells. So if I give dopamine agonist, I can suppress and the tumor size can shrink. Okay. So in that case, what will be my treatment of choice? Treatment of choice will be dopamine agonist and not surgery, regardless of the tumor size. Dopamine agonist, regardless of tumor size. Okay, so you may ask, sir, what if there is a 6 centimeter tumor? No worry, whatever is the size of the tumor, it will still shrink with the dopamine agonist, right? What are the dopamine agonists we know? One is bromocriptine, second one is cabergoline. I have already told you cabergoline is preferred in most cases because it is long acting. This is usually given as once or twice a week, and that is why it is a preferred agent. It is more convenient to administer and it is also more effective than bromocriptine. Bromocriptine is given as TID or QID. That means you need to give 3 or 4 times a day, not week. In that case, it is less preferred, but because of its safety is well proven in pregnancy, this is preferred in pregnancy. If in pregnancy you need to give dopamine agonist, we will be using bromocriptine. That's also an important MCQ. Okay, that's clear. So we have done with growth hormone acromegaly and adult growth hormone deficiency. We are done with hyperprolactinemia and prolactinoma. We will now switch to the posterior pituitary. On the posterior side of the pituitary, there are 2 hormones produced. One is oxytocin, the second one is ADH. As a physician or as medicine as a subject, we have nothing to do with oxytocin. All that we have to do is with ADH. Okay. Now, what is ADH? The name says antidiuretic hormone. Okay. So, what is the main function of it? The name itself says antidiuretic hormone. What is the meaning of diuresis? To lose water. Antidiuresis means to retain water, to stop kidney from losing water. Now, why should a hormone stop kidney from losing water? It does it for maintaining the serum osmolality. So, the main function of ADH is to maintain serum osmolality. Okay. So, now you tell me, if the serum osmolality is rising, what should happen to ADH level? Should it rise or should it decrease? if serum osmolality is increasing. When I say serum osmolality is increasing, what does that mean? The amount of solutes in serum is increasing and the amount of water is decreasing, right? That's why the serum is becoming concentrated. That is when osmolality increases. So now I need to add more water to plasma or less? I need to add more water, right? Because the water plasma is becoming concentrated. So I need to increase the renal absorption of water. So to increase the renal absorption of water, ADH should increase or decrease. ADH is antidiuretic hormone. It stops the loss of water in kidneys. So ADH level should increase. So simple rule is, if serum osmolality increases, it lead to increase in ADH, right? If serum osmolality decreases, that will lead to decrease in ADH. Pretty easy to remember. The ADH and osmolality follow the same direction. If ADH osmolality is increasing, to decrease the osmolality, ADH should increase. If osmolality is decreasing, right, to make you lose more water, ADH should decrease. So they follow the same direction. Okay. Now in terms of pathology, what can happen? If there is excess ADH, the condition is called as SIADH, syndrome of inappropriate antidiuretic hormone secretion. And if there is a deficiency, we call that condition as diabetes insipidus or DI. Okay, so first let us study about the diabetes insipidus. Okay, I have defined it here. Diabetes insipidus is a condition. See, now there is ADH deficiency. So if there is lack of ADH, then renal reabsorption of water won't happen. I don't mean that all that 90% of water is not under the control of ADH. Only 10% of water reabsorption at the kidney is at the control of ADH. 90% is mandatory. That happens at PCT. All that 90% will be reabsorbed, but 10% will be lost if there is no ADH. So if there is, during every cycle, if I keep losing 10%, I will start losing lot of water. Simple. So in terms of symptom, what will it lead to? It will lead to polyuria. Okay. Now ADH is only concerned with regulation of water. It has nothing to do with sodium. It has nothing to do with potassium, unlike your aldosterone. Aldosterone increases sodium and water reabsorption and facilitates potassium loss. But ADH doesn't do that, right? ADH job is only water reabsorption or water loss. So if I'm losing water from the kidneys because of ADH deficiency, I'm only losing water. I'm not losing sodium. I'm not losing potassium. I'm not losing any of the other electrolytes. So when I look at the urine osmolality, it will be very low, right? We call it as dilute polyuria. And this is happening due to ADH deficiency. It can be also because of ADH resistance. Now, what do I mean by resistance? ADH is produced by posterior pituitary. If it is not produced in sufficient quantity, kidneys will not be able to reabsorb water, we develop polyuria. But sometimes pituitary produces sufficient quantity of ADH, but kidneys fail to respond to it. In that case, we call it as ADH resistance. Ultimately, what is happening? Polyuria. Okay. Now here we have to understand, when do you call it as polyuria, right? Polyuria is equal to urine output more than 40 ml per kg per day or per 24 hours. So if like a 50 kg person loses more than 2 liter of urine per day, that means it is polyuria. A 60 kg 2.4 liter, a 70 kg 2.8 liters or more than that will be considered as polyuria. Okay. Now diabetes insipidus is classified into 3 groups. We call them as central, gestational and peripheral. Okay. Now what do I mean by central? We are primarily talking about the pituitary gland. So when pituitary gland is not able to produce the ADH, right? Decreased ADH production by pituitary gland, then we will call it as central diabetes insipidus. Okay. Second, we call something as peripheral, which is also called as nephrogenic diabetes insipidus. Here what happens? ADH action at kidney is impaired. Means ADH production is normal, right? So ADH production is normal, but kidneys fail to respond. ADH production is normal, kidneys fail to respond. Then we call it as nephrogenic or peripheral diabetes insipidus. Then there's a third entity called as gestational. See, pituitary produces, it goes and acts on the kidney. Pituitary doesn't produce, then it is central or pituitary. Pituitary produces but kidneys don't respond to it, then it is peripheral or nephrogenic. But something can go wrong in between, especially during pregnancy. See, the placenta of a pregnant woman produces a hormone called as vasopressinase. It is primarily not vasopressinase, it is a oxytocinase. Because oxytocin and vasopressin are structurally similar, it not only destroys oxytocin but also destroys vasopressin. So pituitary produces in the circulation, the placental hormone destroys it, so ADH doesn't reach the kidney. In that case, we call it as gestational. Okay. Now in the exam, what kind of questions are expected? They will ask you questions related to causes for central as well as nephrogenic diabetes insipidus. 3 or 4 important MCQ point. Number 1, what is the cause for familial central diabetes insipidus? It is due to mutation in vasopressin gene. So pituitary gland, if the vasopressin gene itself is mutated, it will not be able to produce vasopressin. Simple, right? Then there is a second condition called as Did-Mode syndrome. This is a repeatedly asked MCQ template. They have asked which of the following is not a component of Did-Mode syndrome. Sometimes you may get confused with the question because instead of calling it as Did-Mode, they will call it with another name. This is also known as Wolfram syndrome, right? Which of the following is not a component of Wolfram syndrome? Okay. Now, why are we calling it as Did-Mode? It is a condition where patients present with diabetes insipidus plus diabetes mellitus plus optic atrophy plus deafness. This deafness is going to be sensory neural hearing loss. So when all of these things happen together in a patient, we call it as Did-Mode syndrome or Wolfram syndrome. What MCQs they will ask you? First MCQ, which of the following is not a component of Did-Mode syndrome, right? So they can confuse you there itself, like diabetes insipidus, diabetes mellitus, osteoarthritis, deafness. Osteoarthritis seems like OA and you might think that okay, osteoarthritis is the component and you may pick up a wrong answer, right? Remember, diabetes mellitus, diabetes insipidus, optic atrophy, deafness. Vision gone, hearing gone, diabetes, both the types of diabetes, insipidus as well as mellitus. It is due to mutation in a gene known as WFS1. Easy to remember because name of the disease is Wolfram syndrome. So it is like Wolfram syndrome 1 gene. Okay. Other causes not so important. I want you to remember 2 MCQ points here. Familial vasopressin mutation and Did-Mode syndrome. Okay. Then they will also ask you causes for nephrogenic diabetes insipidus, where kidneys fail to respond to the vasopressin, right? So drugs are overall the most common cause in today's context, and among the drugs it is the lithium which is the most common cause. Why do we use lithium in today's practice? Lithium is mostly used for the treatment of mania, right, in psychiatry. Mania and other psychotic disorders, not the neurotic disorders. Okay. And then other than that, antibiotics, HIV drugs, antifungals, cancer chemotherapy drugs, they are also known to cause. I want you to remember only 2 points here. Most common is drugs. Among them, lithium is the most common cause. Okay. Other than that, kidney disorders, then mutation in a gene called as V2R. This is primarily a gene for the vasopressin receptors. Vasopressin receptor type 2 or V2 receptor is present in the kidney which absorb the water. If the receptor is dysfunctional, even if your vasopressin is coming, receptor is not able to absorb the water. And how receptor absorbs the water? Receptor absorbs the water by stimulating a water channel called as aquaporin. Aquaporin 2. So if there is a mutation in aquaporin also, that can also lead to nephrogenic diabetes insipidus. Okay. Now what are the clinical features if I have diabetes insipidus? Patient will present with first. What is the problem? ADH is low, right? So primarily there is decreased ADH production. So that means there is decreased water reabsorption at kidney, right? Reabsorption at collecting tubules and collecting ducts, and that will result in polyuria, right? Remember this polyuria, we are only losing water, no electrolytes, so this will have low osmolality or dilute polyuria, low osmolality or dilute polyuria. Okay, so first symptom that I would anticipate this patient to have is polyuria. Okay, so now if polyuria is there, what will happen to the plasma osmolality? The plasma osmolality, because you're losing water, plasma is becoming concentrated, so the plasma osmolality is increasing. Okay, now your ADH has already failed because of decreased ADH level or its action ADH is not working, but there is another mechanism which will help you to counteract this plasma osmolality, and that is your thirst mechanism. So if your plasma is becoming concentrated and ADH is not able to correct it, it will stimulate your thirst mechanism and you will feel thirsty because of your rising plasma osmolality, and you will start drinking water, right? So if you have polyuria, you will drink a lot of water, and we call that as polydipsia, right? We call that as polydipsia. Okay. Now, can this patient develop the hypotension because they have polyuria? The answer is no. As long as your thirst mechanism is intact and you are able to drink water, you won't develop hypotension. Hypotension only happens, or a dehydration only happens, only patient is not able to take water. Dehydration only happens if patient's thirst center is affected, or thirst mechanism is impaired, or is in a situation where he is not able to drink water or unable to drink water. Otherwise, dehydration is not a feature of diabetes insipidus. They lose 3 liters, they will drink 3 liters. The thirst will stimulate them to drink 3 liters. But if I am bedridden and I have developed diabetes insipidus, I can't take the water, I will not replace the losses, and I will develop dehydrated and I can develop hypotension. Okay. Now there is one more condition called as psychogenic polydipsia. Many questions related to this are based on this, like identify whether this patient has psychogenic polydipsia or whether he has got this diabetes insipidus. Now what happens in polydipsia or primary polydipsia or psychogenic polydipsia? Patient drinks a lot of water. Okay, right? So in case of DI, this is what is happening. You have ADH inaction or ADH deficiency, and that has led to polyuria, and polyuria has led to polydipsia, right? Polyuria leads to polydipsia. On the other hand, in case of primary polydipsia, the pathology is that you have polydipsia, right? You have, in that case, you have increased water intake. If you're drinking too much of water, what will happen to the serum osmolality? You're diluting your plasma, so the serum osmolality will decrease. And I have already told you, right, the ADH follows the direction of osmolality. So if the serum osmolality is decreasing, ADH level will also decrease. Remember this? So now what will happen in a psychogenic polydipsia case? If the serum osmolality is decreasing, that means the ADH level will also decrease. If the ADH level decreases, what will happen to the water reabsorption at the kidney? That will come down, and what will happen to the urine output, right? So decreased water reabsorption at kidney, leading to, this will lead to polyuria. Okay, so polyuria and polydipsia are symptoms of both your primary polydipsia as well as your diabetes insipidus. Here also you have polyuria, you have polydipsia, right? Here also you have polyuria and polydipsia. So all the questions are about how to differentiate between diabetes insipidus and primary polydipsia. Okay. So we will learn the approach to evaluation of a case of diabetes insipidus, how to differentiate it from primary polydipsia. So there are two important algorithms, and I would suggest that you spend 15 minutes learning these algorithms. This will help you to possibly get 1 mark. Okay, so the approach number 1, evaluation or diagnosis of DI, right? Approach number 1, if you have a patient presenting with polyuria, which we have already defined as urine output more than 40 ml per kg per day. This is again an MCQ point. When do you call it as polyuria? If the urine output is more than 40 ml per kg per day, right? Then we have to first look at the urine osmolality. Normal urine osmolality will match the plasma osmolality, or it may be higher. Okay, so normal plasma osmolality is how much? Around 280 to 295 milliosmoles. Urine osmolality is expected to be around that. So if the urine osmolality is more than 300, that means it is a hyperosmolar polyuria. This typically happens when you are not only losing water, but you are also losing solutes or electrolytes, sodium, potassium, glucose. So in those cases, it is not a case of diabetes insipidus. It can be diabetes mellitus. Remember, diabetes mellitus has 3 P's: polyuria, polyphasia, polydipsia. Right? So polyuria is there, polydipsia is there in diabetes. But diabetic polyuria is not difficult for us to diagnose because their urine osmolality will be high because glucose is osmotically active substance. Now if I am giving someone like Lasix, it is a diuretic. It will also make them lose lot of urine, but along with that they will lose sodium, right? They will lose potassium. So their urine osmolality will be high because there is sodium and potassium. Similar is the mechanism of mannitol. On the other hand, if it is diabetes insipidus, the urine osmolality will be very low because we are only losing water. So you will have a very dilute urine. Urine osmolality will be less than 300. And in case of polydipsia also same, because in polydipsia what happens? I am drinking too much of water. So ADH level is going down and I am making body lose too much of water in urine. So I am basically losing too much water only. So I will have dilute polyuria. So these are the two differential diagnoses when you have a case of polyuria with urine osmolality less than 300. Now how do I further differentiate between these two? I do a test called as water deprivation test. So I stop the patient from drinking water. Okay. So if the patient has polydipsia, tell me what will happen to urine osmolality after I have stopped him drinking water. His problem was in a primary polydipsia case, he was drinking too much. That is why his plasma was getting diluted. That's why body was losing too much of water in urine. If I stopped him from drinking, the plasma osmolality will slowly get corrected and his polyuria will decrease and urine will start becoming more concentrated instead of dilute. So after water deprivation test, if the urine osmolality increases, then it is primary polydipsia. If urine osmolality still remains low, like I've stopped him from drinking but still he is losing urine and urine is dilute itself, then it is a case of diabetes insipidus. Now the question is, I have to differentiate whether it is central diabetes insipidus or nephrogenic or peripheral. Okay. Now for this differentiation, what I do is I administer a drug called as desmopressin. Right? What is desmopressin? Desmopressin is vasopressin analog. It's a long-acting vasopressin analog. Okay. Now you only think logically and tell me. You have a patient with polyuria. I check the urine osmolality. It is less than 300. That means there is dilute polyuria. I administered the water deprivation test. And if it was a polydipsia, after I deprived him from drinking, the urine osmolality should have increased. Did not increase, it still remains dilute. That means it is not polydipsia, it is a case of diabetes insipidus. Now, if this patient has central DI, after I give him a vasopressin analog, what should happen to the urine osmolality? What happens in central DI? In central DI, pituitary is not producing vasopressin. I gave a vasopressin analog. Now it will do the job and the urine osmolality will increase to more than 800 milliosmoles per liter. But what about the nephrogenic? In nephrogenic, the problem is with the kidney. Your vasopressin was never low. The kidney were resistant to it. In that case, even after I administer desmopressin, what will happen to the urine osmolality? Vasopressin, native, normally produced vasopressin was not working. What about the externally administered vasopressin? That will also not work and urine osmolality will remain lower than 300 milliosmoles if it is a case of nephrogenic diabetes insipidus, right? So I will summarize this algorithm again because plenty of questions to differentiate between polydipsia and diabetes insipidus and recognize whether it is central or nephrogenic. First, patient will present with polyuria, urine output more than 40 ml per kg per day. In that case, first thing we have to do is check urine osmolality. If it is more than 300, it is not diabetes insipidus. If it is more than 300, that means there are solutes present in urine like glucose or electrolytes. So those causes will come into picture. If it is less than 300, then it is possibly a case of diabetes insipidus, but we have a differential diagnosis, that is polydipsia or primary polydipsia. For differentiation between these two, we do water deprivation test. We stop the patient from drinking water. After that, if the urine osmolality increases, then it is polydipsia. If urine osmolality still remains low, then it is diabetes insipidus. Now, if it is diabetes insipidus, to differentiate between central versus nephrogenic, all we need to do is desmopressin administration test. After giving desmopressin, if urine osmolality increases, that means there was vasopressin deficiency. After giving an analog, the function is back to normalcy and urine osmolality has increased. That means it is central DI. After administering desmopressin also, if the urine osmolality does not increase, that means there is resistance to the action of vasopressin, and in that case it is nephrogenic diabetes insipidus. Okay. Now there is one more algorithm which is the new method. So you may not face questions related to how to analyze this algorithm. Rather, they will ask you which of the following is a new method for diagnosis of the diabetes insipidus. We call it as co-peptin assay. What is co-peptin? When vasopressin is released, along with that in equimolar concentration, another substance is released called as 𝐒𝐿. So we can also check at 𝐒𝐿 level. So if 𝐒𝐿 levels are high, that means vasopressin level is high. If 𝐒𝐿 level is low, that means vasopressin level is low, because they are released in equimolar concentration. Okay, now how do we approach this algorithm? First, you will suspect that a patient may be having diabetes insipidus based on the history of polyuria. PU means polyuria, that to hypotonic, right? How do you define polyuria? Urine output more than 40 ml per kg per day, more than 40 ml per kg per day. And if the patient's urine is hypoosmolar, that means urine osmolality less than 300 milliosmoles per liter, then you will check the serum 𝐒𝐿 levels. Okay, now if the serum 𝐒𝐿 levels are normal, that means more than 21.4 picograms or picomoles per liter, you don't need to remember the number. If it is normal, what does that mean? If 𝐒𝐿 is normal, then vasopressin levels will also be normal. Then why do I have polyuria, polydipsia? Mainly because I have nephrogenic diabetes insipidus. Simple. If the 𝐒𝐿 is normal, that means it is a case of nephrogenic diabetes insipidus. But if 𝐒𝐿 levels are low, right? If they are low, then we have two differential diagnoses. It can be primary polydipsia or central diabetes insipidus. In central diabetes insipidus, vasopressin production is low. That is why 𝐒𝐿 level will be low. In primary polydipsia, the vasopressin production is suppressed because of increased drinking water. So 𝐒𝐿 production will also be suppressed. In both cases, 𝐒𝐿 level will be low. Now, how to differentiate between these two? To differentiate between these two, we do another test called as arginine stimulation test. So we will give arginine. After arginine, if the 𝐒𝐿 level increases, that means the production is not a problem at all. It was being suppressed by patient's habit of drinking too much water. But after giving arginine, it has increased. In that case, it is primary polydipsia. Even after arginine, it is not increasing. That means there is a problem in the factory. The pituitary gland has a problem. In that case, I will call it as central diabetes insipidus. Okay, clear? Now this algorithm, if you're not able to remember, it's fine, but I want you to remember the name. They might ask you 𝐒𝐿 assay or 𝐒𝐿 levels are used for diagnosis of which of the following condition? Diabetes insipidus. This water deprivation test algorithm, I want you to remember, because this is the standard template of MCQs. Okay. Now, having understood diabetes insipidus, it's time for us to discuss the management. Obviously, management will be different for nephrogenic diabetes insipidus and central diabetes insipidus. Okay, how? Number one, if it is central diabetes insipidus, that means pituitary is not able to produce the vasopressin. Then what can we do? We can replace that with an analog. So we use the desmopressin. So desmopressin is considered as the drug of choice for central diabetes insipidus. Desmopressin is a long-acting analog of vasopressin. If I have to give vasopressin, I have to give a continuous infusion. Not practically possible. I can't keep the patient eternally in the hospital. So I will give a long-acting analog. So basically, desmopressin is a long-acting ADH or vasopressin analog. What other drugs that I can use? I can use clofibrate, chloropropamide and chlorpromazine, right? So simplest way to remember it, you know, cafe coffee day, CCD, right? CCD. These are the drugs for the diagnosis of central diabetes insipidus or pituitary diabetes insipidus. In case of nephrogenic diabetes insipidus, thiazides are considered as the drug of choice. Thiazides are considered as the drug of choice. But if, see, remember what is the most common cause for nephrogenic diabetes insipidus? It is lithium. If lithium induced diabetes insipidus, then amiloride is the drug of choice. So these are all MCQ points. Overall, what is the drug of choice for nephrogenic diabetes insipidus? What is the drug of choice for lithium induced diabetes insipidus? And what is the drug of choice for central diabetes insipidus? Okay, so I hope the posterior pituitary is clear. Now from there we will move to the next disease, which is our Cushing syndrome. Now the very first question that we need to address here is that we hear the term Cushing syndrome and Cushing's disease. What is the difference between the two? So remember here, Cushing syndrome simply means any condition where there is chronic excess cortisol, chronically elevated serum cortisol levels, then we will call it as Cushing syndrome. Then what is Cushing disease? When this excess cortisol is due to, right, chronic excess cortisol due to ACTH producing pituitary tumor, producing pituitary adenoma, then we call it as Cushing disease. So can I say, there was one statement in the FMGE exam that Cushing disease is a cause for Cushing syndrome. Is that a true statement or false? What do you think? It's a true or false statement? Remember, it's a true statement, because overall any condition where serum cortisol is chronically elevated, we call it as Cushing syndrome. If I give you steroids, you take it for 6 months, 7 months, and your steroid action is high, that is Cushing syndrome, right? If I have a pituitary adenoma which produces ACTH, ACTH goes and stimulates the adrenal gland to produce the cortisol, and that is why cortisol is high, that is also an example for Cushing syndrome. Okay. If I have a tumor in the adrenal gland which is producing cortisol, and that's why my cortisol is high, that is also Cushing syndrome. So in simple words, any condition where cortisol is high for a long period of time is Cushing syndrome. If this high cortisol is coming because of an ACTH producing pituitary adenoma, then we call it as Cushing disease. So Cushing disease is an example for Cushing syndrome. Cushing syndrome is an umbrella term, right? Under that, all the causes for excess cortisol come into picture. Okay. Now the causes for the Cushing syndrome or the causes for excess cortisol will be divided into two groups: ACTH dependent causes and ACTH independent causes. Now what is the normal axis of the cortisol production? The hypothalamus produces ACTH, the CRH, corticotropin releasing hormone, and this CRH stimulates the pituitary gland to produce ACTH, and this ACTH goes and stimulates the adrenal gland to produce cortisol. That is how the mechanism works, right? That is the mechanism or the axis. We call it as hypothalamo-pituitary axis or HPA axis. This is what we call as HPA axis. Okay. Now cortisol level can increase without the excess ACTH, or it can also increase because of increased ACTH. So if there is an increase in ACTH and because of that cortisol is high, then those causes will be called as ACTH dependent causes for Cushing syndrome. And if the ACTH is normal or decreased but still cortisol is high, then we will call them as ACTH independent causes for Cushing syndrome, right? For the ACTH dependent, the most common cause is a ACTH producing pituitary tumor. There is a tumor in the pituitary which produces ACTH, and this is exactly what we call as, right? This is nothing but Cushing's disease. Cushing's disease, right? Other than that, if there is an ACTH coming from other sources other than the pituitary gland, then also it can cause, we call that also as ACTH dependent. Now, the most common ACTH dependent cause is the pituitary adenoma. Now coming to the ACTH independent, the most common cause for ACTH independent Cushing syndrome is exogenous administration of steroids or iatrogenic cause. Like we prescribe steroid for nephrotic syndrome, this, that, even when not indicated, that can lead to Cushing syndrome, and that is the most common exogenous cause for the most common ACTH independent cause for Cushing syndrome. Other than that, if adrenal gland has a benign or a cancerous tumor, that can also produce excess cortisol. These are all ACTH independent, right? The cancer or a benign tumor does not require ACTH, it will keep producing cortisol. Now once I have a chronically elevated cortisol, what are the clinical features I can present with, right? So the first thing that I can present, and that is what is usually mentioned in the question, is moon phase. Now why moon phase? Basically when cortisol is high, cortisol is opposite to growth hormone. Means what growth hormone does? Increases your muscle mass, decreases your fat mass. Cortisol does the opposite. Decreases your muscle mass, increases your fat. So basically there is decrease in muscle and increase in fat. So if the fat starts accumulating, it will all accumulate on my face, under the cheek, under the neck. So gives a round shape to the face. This is what we call as moon face, right? Chand sa roshan chehra. Okay. Then when cortisol is high, we will develop pimples or acne. Right? Normally, why stress increases acne? Because of the rise in cortisol. Stress, cortisol, acne. Okay. Then you can have thinning of hair, you can have easy bruising and redness of the cheek, and then fat accumulation behind your neck leads to buffalo hump. That is a second feature that you need to remember, buffalo hump. You can see here fat accumulation here. Okay. Then you can have increased body and facial hair. Weight gain, extremely important, because if you are chronically stressed also we get weight gain because of this high cortisol. Okay. Then you will have this pink purplish striae on the abdomen. This is very classical. Many a times image based questions have appeared, and obviously there is abdominal obesity, so you will have a pendulous abdomen. Okay. Now if I give steroids, right, there will be vascular atrophy and skin atrophy, and it makes the risk of easy bruising. Okay. Then because of the muscle atrophy, there will be thinning of the extremities. There will be also thinning of the skin and subcutaneous tissue. Basically cortisol causes atrophy of tissues, right? And wound healing will also be slow. Basically you can think that you are giving steroid to a patient and all the manifestations you can expect you will see. Apart from that, there will be increase in blood glucose. So patient may become diabetic under the influence of excess cortisol. And like if we give steroids, what happens to the bone mass? Decreases, causes osteoporosis, right? So even Cushing syndrome can have osteoporosis. So these are the symptoms I can expect once I have the Cushing's syndrome. So based on this, I may suspect that patient has Cushing syndrome. Now how do I process for the diagnosis? Now diagnosis will get bit confusing. It may be different from what you have studied in physiology or pharmacology or your previous editions of apps, notes or the offline classes, because it keeps changing. Okay, so let us spend some time understanding this algorithm. If we have a clinical suspicion of Cushing's syndrome based on the features that we just discussed, right? I forgot to mention one point, that there is thinness of the muscle, there is muscle loss, right? So you might have studied in neurology that whenever muscles are affected, what is the presenting complaint? Patient generally present with proximal muscle weakness. Proximal muscle weakness, or what we call as proximal myopathy. We call this as proximal myopathy. So muscles of your hip girdle and your shoulder girdle become weak. So patient will have difficulty in climbing, difficulty in combing, difficulty in raising arms above head, difficulty in lifting objects from the ground, difficulty in getting up from the sitting position. These are the symptoms when there is a proximal muscle weakness. Okay. So if there is a clinical suspicion that patient may be having Cushing syndrome, then you will do certain screening tests. Now in 2022 onwards, there is no difference between a screening test and a confirmatory test. Previously we had screening test and then a confirmatory test. We don't have such distinction now. So first thing that you need to do is, if there is a clinical suspicion, subject the patient for the screening test, and if they're strongly positive, you're done with the diagnosis. If there is still doubt, then only we go for the confirmation test. Unlike before where screening test is positive, then confirmatory test should be positive to call it as Cushing syndrome. Not anymore, right? So what are the screening tests? The screening test number 1 is your urine free cortisol excretion, right? 24-hour urine free cortisol, or UFC, urine free cortisol. If it is more than 2 times the upper limit of normal, that means you have Cushing syndrome. Okay. The second test is dexamethasone overnight test. Overnight test. Don't. Dexamethasone overnight test. So what we do is, we will give 1 milligram of dexamethasone at 11 p.m. and next day at 8 a.m. we will check the cortisol. If it is more than 50, that means it is high. That means you have Cushing's syndrome. Because remember, what is dexamethasone? It is a steroid. If I give steroid, there should be a feedback inhibition of ACTH production and the natural cortisol should come down. If it is not coming down, that means there is a pathology. Simple, right? Okay. Then the third test that we can do as the initial investigation is midnight salivary cortisol. Midnight salivary cortisol. In the middle of the night, ask the patient to give the saliva and check the cortisol levels in the saliva, right? So these are the initial tests. So if these tests are positive, strongly positive, clearly more than 2 times the upper limit of normal, you don't need any confirmatory test. It is a case of Cushing syndrome. You can evaluate further. But if these tests are elevated but not at the cutoff levels, in that case you need confirmatory tests, right? If further confirmation is needed, in that case what test is preferred? We call it as, if confirmation needed, then we have a test, we call it as low dose dexamethasone suppression test. Then we do what is called as low dose dexamethasone suppression test. low dose dexamethasone suppression test. So here we give a very low dose, that is around 0.5 milligrams of dexamethasone every 6th hourly for 2 days, and then after the 2 days we will check the plasma cortisol. Or instead we can do a single dose overnight dexamethasone suppression test, which is 8 milligrams of dexamethasone. Okay, that is only when confirmation is needed. If these are clearly positive, we don't need. So this will establish that what I have is an excess cortisol state, right? If that is positive, now I need to identify whether it is an ACTH dependent cause or an independent cause. How will I do that? I will check the plasma ACTH levels. If the plasma ACTH levels are high, that means it is an ACTH dependent cause, and if the ACTH levels are low, that means it is an ACTH independent test, right? Independent Cushing's. If the ACTH independent is there, that means pituitary adenoma is not responsible for ACTH production. Then what does it mean? The problem may be in the adrenal gland. I have told you ACTH independent causes, right? Adrenal adenoma and adrenal carcinoma. So what should I do if the ACTH levels are low? In that case, it means I have to scan the adrenal gland with a CT scan. Simple. Okay. On the other hand, if I am ending up with ACTH dependent Cushing's as a cause, that means there is a pituitary tumor most likely, that is the most common cause. So I will start the investigation with the MRI of the pituitary gland, right? That is the most common investigation I would need. If that identifies that I have a pituitary tumor there, diagnosis is done. If I am not able to identify, then I have to do additional test. As of now, at the level of FMGE, I am not expecting them to go into the details of these questions, so you may ignore. All you need to do is, if it is ACTH dependent Cushing's, what is the investigation of choice? That is MRI of the pituitary gland, because pituitary tumor is the most common cause. Clear? Okay. Now once I have established the diagnosis that it is a case of Cushing syndrome, right? How do you treat? So number one, treat underlying cause. Right? Now in terms of underlying cause, what are the possible causes? If there is a pituitary adenoma, right? If there is a pituitary adenoma, then we have to treat it with transsphenoidal pituitary adenoma or tumor resection. Okay. Now if it is because of, for example, let me say if it is because of iatrogenic, right? I am giving too much of steroids to the patient, then we have to withdraw steroids. Obviously you cannot abruptly stop because there is a HPA axis suppression, so you have to withdraw. First taper and then slowly taper and stop. Okay. Then second, apart from this, you might opt for medical management. Now what do we do in medical management? Basically we will give drugs which will inhibit this cortisol synthesis. So basically we will inhibit cortisol synthesis. So I want you to remember 3 drugs here which inhibit cortisol synthesis. Number one, meteropon. Second one is ketoconazole. These are actually most commonly used drug. There's a third drug which also inhibits the cortisol synthesis, but it also causes destruction of the adrenal gland, leading to various severe consequences. So not routinely used. Preferably we use meteropon or ketoconazole. This mitotain is also called as adrenolytic agent. So there is an MCQ asking you which of the following is known as adrenolytic agent. It is mitotain. And I want you to add one drug to the list, which is mifepristone. Right. Now mifepristone is going to act as a glucocorticoid receptor or cortisol receptor antagonist. Glucocorticoid or cortisol receptor antagonist. So if I have excess cortisol, but if I block its receptor, then all its consequences or manifestations will be suppressed. This is a supportive treatment, right? Drugs are not the mainstay of treatment. Most common cause for the ACTH dependent is a pituitary adenoma. Remove it. Most common cause for the ACTH independent is the iatrogenic. Withdraw and stop, right? When you need support, you can also give the drugs to reduce the adrenaline's action. Okay. So now that kind of brings me to the basic closure of important topics under endocrinology. Now there are something that is missing. What are the adrenal gland, which will be covered by the surgery colleague who is going to start after probably after medicine, maybe OBG or surgery. So he will address the adrenal gland. Okay. Now there is also one more topic that I have not addressed, which is diabetes mellitus, but I will take you through important MCQs related to the diabetes mellitus. Okay. So we will start with a quick revision of some of the important PYQs. So here is the first question. Image of a patient with weight loss and increased blood glucose. What is the most likely diagnosis, right? So first look at the image and comment what do you see there. Look at the comment and tell me what do you see there. What is the image finding that you're seeing here? I'm waiting for your response, guys. There may be a lag between me streaming and the result. So please take a look at the image and tell me what do you see and what is this finding called and what is the diagnosis. What is the diagnosis? Right. So what do we see here is acanthosis nigricans, right? Acanthosis nigricans. Now what is acanthosis nigricans? Basically there is increased keratin and increased pigmentation. Now why is this happening? This happens, right? Acanthosis nigricans, it is generally due to increase in insulin levels. Why increased insulin levels will lead to acanthosis nigricans? Increase in insulin levels will lead to acanthosis nigricans because see, when we were talking about growth hormone, I told you what mediates the growth hormone's action. The growth hormone's action is mediated by a substance called as insulin-like growth factor 1 or IGF-1. Why are we calling it as insulin-like growth factor 1? Because structurally it is similar to insulin. Its mechanism of action, receptors are all similar to insulin. And we have to remember here that insulin is also a growth factor. Insulin can also stimulate tissue growth. So that insulin is stimulating the keratinocytes and that is why there is keratin production. Insulin is stimulating the melanocytes, that is why there is pigmentation. Clear? Now among these options, in which condition insulin levels increase? Right, like, okay, what is the cause for type 1 diabetes mellitus? Type 1 is mostly due to insulin deficiency, right? There is absolute deficiency of insulin. Clear, right? Now in addition, this is, you can have hyperpigmentation but not acanthosis nigricans. In addition, there is hyperpigmentation but not acanthosis nigricans. Okay. Now what is MODY? MODY is maturity onset diabetes in young, right? So in MODY, the insulin levels will be normal. So okay. Now what happens to insulin levels in type 2? What is the mechanism of development of hyperglycemia in type 2? Hyperglycemia in type 2 happens because of insulin resistance. It is due to insulin resistance. So if there is insulin resistance, what will happen to the insulin levels initially? If insulin is not able to do its work, what body will do? Insulin is not able to work, it is not able to push the glucose into tissues, blood glucose level is still high, body will produce more insulin, it will produce more insulin. So as a response to insulin resistance, there will be hyperinsulinemia, right? It will lead to hyperinsulinemia. And this hyperinsulinemia can lead to acanthosis nigricans, right? Because insulin, if it is high, it leads to acanthosis nigricans. So remember, any diabetic, if you see that they have acanthosis nigricans, then there is no second thought about it. It is a case of type 2 diabetes mellitus. Clear? Diabetic with acanthosis nigricans is type 2 diabetes mellitus. So there I am giving you some important MCQ point. Markers of insulin resistance. Markers of insulin resistance. Insulin resistance is seen in type 2 diabetes mellitus, right? What are those? Number 1, acanthosis nigricans. Okay. And number 2, skin tags, right? Especially those who are little obese and you have started noticing skin tags, that means you've already developed insulin resistance, right? You have to remember that we have already developed insulin resistance. You are inching towards becoming type 2 diabetes mellitus. So recognizing type 2 is pretty damn easy. Diabetes with signs of insulin resistance is equal to type 2 diabetes mellitus. Clear? Okay, so this is going to be an important MCQ point for you. Okay, now let us move to the next question. The second question is, what is the most common cause for Addison's disease in developing countries? Okay, so let me tell you first what is Addison's disease. Addison's disease. Okay, what is Addison's disease? Can I say Addison's disease is equal to cortisol insufficiency? Cortisol insufficiency can happen because of various causes, right? So let me put a small sheet here. Okay, hypoadrenalism or cortisol insufficiency, right? Hypoadrenalism can happen because of the adrenal gland dysfunction. In that case, we can also call it as primary hypoadrenalism, and it can also happen because of the decreased ACTH or decreased corticotropin releasing hormone production, right? In that case, we will call it as secondary hypoadrenalism. Okay, the most common cause for secondary hypoadrenalism is iatrogenic steroids. If I give someone steroids, the steroids will suppress ACTH production, and if the ACTH production is suppressed, then even the natural cortisol production will be suppressed. And if I withdraw the steroids, I have already suppressed the ACTH production, and sufficient cortisol will not be produced, and patient will have manifestations. Okay. Now, if it is primary, we call it as, if it is primary, we will also call it as Addison's disease. Addison's disease. And for Addison's disease, the most common cause in developed world is autoimmune adrenalitis or autoimmune cause, right? Adrenal damage because of autoimmune. But most common cause in developing countries, including India, right? In developing countries, autoimmune is relatively less common. It used to be tuberculosis. So when I wrote the exam, this question was there in my NEET, not the NEET PG. That time we used to call it as All India. This question was there, and the answer was tuberculosis. Well known back then. Until recent times, we used to claim that tuberculosis is the most common cause for adrenal gland insufficiency or hypoadrenalism in developing countries, including India. But in the recent times, HIV has replaced it, right? So HIV is more common than tuberculosis. So right now, if this year they ask the question, your answer should be HIV. So this PYQ, when it was asked in 2018, the answer would have been tuberculosis, but now it is HIV. And if they ask overall, what is the most common cause, right? Whether without mentioning developed country, overall also right now it is HIV. Okay, so is that clear? Now going back to the question, what is the most common cause for Addison's disease in developing countries? The answer is very clear, right? It is HIV. Clear? Okay. What is Addison's disease? It is primary adrenal insufficiency. Adrenal insufficiency. Problem is in the adrenal gland, it is not able to produce. So HIV, virus is suppressing adrenal gland action, or tuberculosis is affecting the adrenal gland action, and that is why there is decreased adrenal activity. Okay. Question number 3. Which of the following type of diabetes mellitus is known as type 1A diabetes mellitus? Which of the following is known as type 1A diabetes mellitus? Mere tuberculosis used to be, that's why I have modified this question. So when this appeared in the FMGE, yes, tuberculosis would have been the answer, but if this appears again, the HIV will be answer. Okay. So this was our question number 3, right? Which of the following type of DM is known as type 1A diabetes mellitus? Okay. So a little bit about the classification of DM, then we will answer the question, right? Diabetes mellitus classification. Okay. So now diabetes mellitus, we classify them into 2 broad groups as monogenic and polygenic. So when I say polygenic means multifactorial, we cannot pinpoint a single cause as a cause. Monogenic is generally due to single gene mutation. Okay, so there are two types here. One of them is MODY, maturity onset diabetes in young. The other one is your neonatal diabetes mellitus or NDM. Okay, now MODY is important for the exams, and other than MODY, polygenic, we will further classify them into type 1, okay, type 2, then we have an entity called as latent autoimmune diabetes of adults or LADA, which is also known as type 1.5, okay, and then one more, that is gestational diabetes mellitus. Okay, the type 1 is due to insulin deficiency, right? Absolute insulin deficiency. Your pancreas is not able to produce insulin. Type 2, pancreas initially at least is able to produce insulin. Unfortunately, that insulin is not able to work because it is due to insulin resistance, right? Overall, type 2 is the most common type of diabetes mellitus. Okay, now in type 1 we will further divide them into two groups. We will divide them into type 1A and type 1B. Type 1A is caused by an autoimmune damage to pancreas, right? It is an autoimmune diabetes mellitus. And type 1B, we don't know the cause. We will call it as idiopathic. Okay, so now tell me how to remember it. Pretty easy, right? A for autoimmune, simple, right? A for autoimmune. Type 1A is autoimmune, 1B is idiopathic. Simple. Okay. Now, what else we need to know is that we need to also know what is LADA and what is MODY. I will address both these points later. Okay. So now we know the basic classification of diabetes mellitus. So this is one topic that I have addressed. This is second topic that I am addressing. We'll go back to the question now. Which of the following type of diabetes mellitus is known as type 1A, right? Simple question. Autoimmune type 1 diabetes mellitus is known as type 1A. So that will be the answer, right? Autoimmune diabetes mellitus is type 1, right? So the idiopathic will be known as type 1B, right? LADA is known as type 1.5. MODY is nothing to do with types. It is an independent entity. Okay. Now we will go through the fourth question. Weight loss is seen with all of the following drugs except empagliflozin, liraglutide, metformin, glimepiride. Okay. Weight loss is seen in all of the following except. See, one of the problem of diabetes treatment is that especially type 2 diabetics, they are already obese or overweight. When we start treating them with drugs, especially the drugs which will increase the insulin production. What is the function of insulin? It will take the glucose from your blood, put it into your adipose tissue and liver and muscle as glycogen and fat. So it will increase weight. So insulin directly increases weight. The drugs which will increase insulin will also increase the weight. Okay. So now question, right? What is empagliflozin? Empagliflozin is a SGLT2 inhibitor. SGLT2 inhibitors will decrease the reabsorption of the glucose from the urine. So you will lose a lot of glucose in urine. When I lose glucose, I am losing calories. So when I am losing calories, I am losing weight. So it's a good drug for weight loss. Okay. Now what is liraglutide? It is a GLP-1 analog. So if I give liraglutide to someone, right, I will suppress their appetite. Their eating will come down and they will lose weight. So liraglutide is approved for even treatment of obesity. This is also approved for treatment of obesity. Even when you are not diabetic, we can give it to you. So obviously that causes weight loss. Metformin is a controversial drug because some books and some studies show that it causes weight loss. Some books and some studies show that it doesn't cause weight loss. But I can clearly say that it doesn't cause weight gain. So metformin, right, either decreases weight or does not affect weight, but it will not cause weight gain. Now, what is the mechanism of action of glimepiride? Glimepiride primarily is a sulfonylurea. It is a sulfonylurea. So sulfonylureas are insulin secretagogues. They will stimulate insulin secretion. So when insulin secretion is caused, the insulin will take the blood glucose, convert it into fat and glycogen. So what will happen to weight? Weight will increase. So glimepiride causes weight gain. It causes weight gain. So what should be the correct answer for this question? It would be option D. Glimepiride causes weight gain, doesn't cause weight loss. So I can confidently pick that as an answer. Though metformin is controversial, clearly it doesn't cause weight gain for sure. Glimepiride causes weight gain. So when they're asking cause weight loss except, obviously option D would be the answer to go for. Okay. Next question. A diabetic patient presented with burning feet. Okay. In a diabetic, if they present with burning feet, what should come to your mind first? Mostly diabetic peripheral neuropathy. Okay. Now the question is, the following test is used for. Following test is used for the diagnosis of what? Okay. So what do you think is the diagnosis here? What do you think is the diagnosis, or what is that test that they are doing? Okay, so this equipment that they are using, right? This equipment is available in various forms. This may be, you may see a card like this with a filament attached to it, or there may be a knee hammer like stuff with a filament attached to it. So primarily there is a filament here, right? So this filament is called as 10 gram monofilament test. The filament is called as 10 gram monofilament. So you can call this as 10 gram monofilament test, or it is also known as, this is also known as Weinstein filament test. Okay, so for what purpose we do this? This is not done for the diagnosis of diabetic neuropathy, unfortunately. Whenever this question has appeared in FMGE, almost always students have choose diagnosis of diabetic neuropathy. Remember, the diagnosis of diabetic neuropathy is based on clinical plus nerve conduction studies and not based on this test. Okay. Now in diabetic neuropathy, basically peripheral nerves are affected. Peripheral nerves are part of lower motor neuron. So obviously I can't use this test for the detection of upper motor neuron, right? Then the option D, diagnosis of peripheral vascular disease. So if I have to diagnose peripheral vascular disease, I should feel the pulse. I shouldn't be doing something with a filament. I should be feeling the pulse. If the pulse is decreased or absent, then there is a peripheral vascular disease. Or more ideally, the investigation of choice would be the arterial Doppler. If I'm suspecting peripheral vascular disease, like you have this thromboangiitis obliterans, you will do a Doppler. So this is basically done for identification of LOBs. So now the question is, what is this LOBs, right? So you should certainly know the full form of LOBs. LOBs stands for loss of protective sensation. Loss of protective sensations. So first you make a diagnosis of the diabetic peripheral neuropathy on the clinical grounds with a history of diabetes, burning feet and all those symptoms. Now I have to understand whether this patient is able to protect his feet from injuries or not. Why this is important? Because if there are multiple injuries, the wounds in a diabetic will not heal and it will lead to what we call as diabetic foot. Sometimes we have to amputate the diabetic foot because it doesn't heal well. So we have to assess whether the patient is able to protect his feet or not. So if he is able to feel this filament, that means he will be able to protect his feet from injuries. He will recognize the injuries and get it addressed. If he is not able to feel the filament, that means he has lost the protective sensations, and such patients' feet need extra care, like regular inspection, specialized footwear, so that he doesn't suffer from small micro injuries which can turn into diabetic foot, right? So LOBS here stands for loss of protective sensation, and this sum is Weinstein filament or this MS Weinstein filament or 10 gram monofilament test is used for identification of loss of protective sensation and not for the diagnosis of the diabetic neuropathy, right? So these are not the answers. Option B would be the answer to go forward. Okay, next question. Which of the following is the preferred method for assessing glycemic control in diabetic? This is an FMGE repeat question, but the answer is going to change this time. So if you have a diabetic, the tuning fork vibration test, yes, you can use it for recognition of loss of sensations, but that cannot be used for recognition of loss of protective sensations. Okay. So yes, it used to be the HbA1c as the standard or a preferred method for assessing the glycemic control, how good the blood glucose level is controlled. But from 2022 onwards, the ADA guidelines have changed. So ADA guidelines in this year clearly recommend not the HbA1c, right? Why not HbA1c? Because HbA1c has its own pitfalls. If the patient's hemoglobin is already low, the HbA1c will also be low. If patient has hemoglobinopathy like thalassemias, his HbA1c will be low, right? If the patient is going through acidosis, his HbA1c will be high. So HbA1c is not a foolproof investigation, right? So that is why now the 2023, the preferred recommendation is to do something called as CGM, right? What is CGM? CGM stands for continuous glucose monitor. Glucose monitor. So that is a preferred method. It's like you might have seen some sports enthusiasts, even you might have seen me wearing a CGM device, right? Like there's a small device which we insert into the subcutaneous plane and it will record our blood glucose level continuously for how many days? 14 days. So during these 14 days, we will calculate many parameters. What was the average blood glucose level? What was the lowest level? What was the highest level? What percentage of time it was above the recommended level? What percentage of time it was below the recommended level? So we will understand clearly what is happening to patient blood glucose level. When we do HbA1c, we will only get the average of 3 months, nothing more than that. We will not know the lowest value, highest value and all. And that is why it is the preferred method currently, CGM, continuous glucose monitor. Okay. So if the question appears this year, the answer should be CGM. In the previous year's question, the answer would have been HbA1c. Okay. Next question. Which of the following is not true about MODY? Which of the following is not true about MODY 2 or MODY? What is MODY? Maturity onset diabetes in young, right? Option A, insulin resistance, autosomal dominant, onset less than 25 years, need not always require insulin. Which of the following is not true? So I have already told you this one point, right? Acanthosis nigricans plus diabetes is equal to what? Type 2 diabetes. Simple, because insulin resistance is only seen in type 2 diabetes. Type 1, there is insulin deficiency. There is no question of insulin resistance, right? LADA is also a type of insulin deficiency. MODY has nothing to do with insulin resistance, right? So we will add few points about MODY here. Okay. So we will add few important points about MODY. What MODY stands for? MODY stands for maturity onset diabetes of young. Okay. Now MODY, neither there is insulin deficiency nor there is insulin resistance. Then what is the problem? No insulin resistance. Then what is the problem? The problem is that the pancreas fails to sense the blood glucose level. See, normally what happens? Blood glucose level goes up, pancreas senses it, produces insulin. If it is able to produce insulin, then it is certainly not type 1. In type 1, it senses but unable to produce insulin. Okay. If it is able to produce insulin, the insulin will go and act on the tissues to decrease the blood glucose level. But if tissues are not responding because there is resistance, then it is type 2. Now the problem in case of MODY is pancreas ability to sense the blood glucose level is only affected. So even when blood glucose level is rising, the pancreas is not able to recognize the rise and it is not able to produce appropriate quantity of insulin. So Insulin production capability is normal, but pancreas is not sensing it. Okay, so there is no insulin resistance, neither insulin production is affected. So here it is due to failure in blood glucose sensing mechanism of pancreas. So there are various nuclear factors involved in blood glucose sensing that mutations in it is generally due to nuclear factor mutations. Okay, and these are generally inherited as autosomal dominant conditions. So that is why for the diagnosis of MODY we need to have history of DM in more than or equal to 2 generations. At least 2 generations before this index case. So that means total 3 generations should have the diabetes, because it is an autosomal dominant. There is no escape, right? I will transfer it to my kid. My kid will transfer it to my next generation because it is an autosomal dominant condition. Okay. Now, why are we calling it as maturity onset diabetes in young? That means it doesn't start in the pediatric age group. After you mature, you attain your teenage, that is where it can start, and it will only occur in young individual. It will be recognizable in young individual. So first point to note here is that it is autosomal dominant. So you need the family history. Second, the patient will present with hyperglycemia before the age of 20 years, before 25 years of age. Okay. Now there are different types of MODY. They are generally numbered as MODY 1 through, right now we have up to 14 types of MODY. Okay. There are few MCQ points I want you to remember about MODY. So first question is most common type of MODY. Okay. The second question is MODY with renal cysts. So there are MODYs which are associated with renal cysts. Which MODY is associated with renal cysts? That's also an important MCQ. Okay. So the most common MODY is MODY type 3. Okay. And the MODY with renal cyst is MODY type 5. Okay. So I want you to remember these two important MCQs. The most common MODY is MODY type 3. The most common, the MODY associated with renal agenesis or renal cyst is MODY type 5. Okay. So if that's clear, let us get back to this question. Which of the following is not true about MODY? MODY is autosomal dominant. Yes, it is autosomal dominant. Onset under 25 years, that is true, right? Because there is no insulin deficiency, you need not always treat them with insulin. Some patients may respond to diet alone. Some patients may do well with sulfonylureas. So this is also true. There is no insulin resistance in MODY. So that becomes my answer of choice. There is no insulin resistance in MODY. So option A would be the answer of choice. Okay. Now the next question. The following lesion seen in a diabetic, what is it known as? Erythema nodosum, erythema marginatum, necrobiosis lipoidica, or lipoatrophy. Okay. So I will directly tell you answer. It is necrobiosis lipoidica, right? So what is necrobiosis lipoidica? Necrobiosis lipoidica is a non-healing granulomatous lesion. Non-healing granulomatous lesion seen in diabetics. Lesion most commonly seen on shin, right? It's a rare complication of diabetes. Rare complication of diabetes mellitus. Okay. Now where do we see lipoatrophy? Lipoatrophy can be seen as a side effect of insulin therapy. Side effect of insulin injection. So when you take insulin injection at same site repeatedly, the fat at that location can get atrophied. That is a side effect. So what we see here is necrobiosis lipoidica. There's an image of a shin. You can see a raised lesion, a non-healing type of a lesion. It almost looks like edematous because it is a granulomatous lesion. Okay. Now here is our question number 9. All are common features of Cushing syndrome except. Okay. I have discussed today Cushing syndrome and the clinical features, and there is one beautiful image for us to remember. Right? What is that image? So here is the image. What do we see? We see acne, moon face, buffalo hump, right? Obesity, weight gain, pink purplish striae, ecchymosis and easy bruising, right? Atrophy of the muscles predominantly affecting the proximal muscles causing proximal myopathy, slow or delayed wound healing, and thinness of the skin and subcutaneous tissues. Okay, so now let us get back to the question. All are common features of Cushing syndrome except. Do we see truncal obesity in Cushing syndrome? Yes, that's true. Do we see osteoporosis? Yes, I have told you, right? If I give steroids to someone, the bones go weak. So if the body is producing too much steroids, bones will go weak. That is true, right? Glucose intolerance, yes, I have told this also to you. When cortisol is high, we will develop insulin resistance. So your glucose levels will increase. So it can also lead to diabetes. But when muscles get affected, right, generally most of the diseases that affect muscle, they affect proximal muscles more than distal. This is what we have also discussed in neurology localization. So distal myopathy is not seen in Cushing syndrome. Rather what we see is, we see proximal myopathy. Proximal myopathy will be seen, not distal. Proximal myopathy is seen in Cushing's. So option C would be the correct answer for this question. Okay. Next question. ACTH dependent Cushing syndrome is caused by. Simple, right? We have also studied this. What is the most common cause for ACTH dependent? When there is a pituitary adenoma which is producing ACTH, that ACTH will go and stimulate the adrenal gland to produce cortisol, right? So pituitary producing tumor of the pituitary gland producing ACTH, stimulating the adrenal gland to produce cortisol, leading to Cushing syndrome. So the most common cause for ACTH dependent Cushing is going to be a pituitary adenoma, right? Pituitary adenoma that produces ACTH. This will produce ACTH. This ACTH will stimulate adrenal gland to produce cortisol, right? Produce cortisol. This cortisol lead to Cushing's syndrome, and this Cushing syndrome is what we also call as Cushing's disease. Cushing's disease. Cushing disease is nothing but Cushing syndrome due to a ACTH producing pituitary adenoma. Okay. Next question. Most common cause for Cushing syndrome. So this is the overall general question. What is the most common cause for Cushing syndrome? They are not asking you ACTH dependent or independent. If they ask independent, we know iatrogenic. If they ask dependent, we know pituitary adenoma. If they ask a general question like this, what should be our answer? So I can tell you from my experience also, in last 5 years, whatever cases of Cushing syndrome I have seen, right? To be very frank, I have not seen a single case of a pituitary adenoma. All of them were because someone had started the patient on steroids. So overall, the most common cause for Cushing's syndrome is iatrogenic steroids. So this is the overall most common cause for Cushing syndrome. Overall most common cause for Cushing's syndrome. And this is also the most common cause for ACTH independent Cushing's syndrome. Pituitary adenoma is the most common cause for ACTH dependent Cushing syndrome. Cushing's syndrome, which is also called as Cushing's disease. If an ACTH producing pituitary adenoma is there, we also call it as Cushing's disease. So now what should be the correct answer here? Option C. Iatrogenic steroid administration is the overall most common cause for the Cushing syndrome. So question wise, please read it carefully. If they do not mention dependent, ACTH independent, then iatrogenic steroids. If they mention ACTH dependent, then a pituitary adenoma. If they mention ACTH independent, again iatrogenic steroids. Okay. Now the guys, last question for the day, and then we will wind up the quick revision of endocrine. Confirmatory test for acromegaly, right? I have given you a simple clue. If you are thinking of a condition where there is a excess of hormone, then the confirmation will be trying to suppress it. If you are able to suppress, it is normal. If you are not able to suppress, that means there is true excess. And similarly, a confirmatory test for a hormone deficiency condition is a provocation test. Like I will give a substance to stimulate the hormone production. If it increases, that means it is normal. If it doesn't increase, that means there is true deficiency. So what should be the answer here? Right. So the answer should be glucose suppression test. Right. This is the confirmatory test. If there is acromegaly, what should happen after the glucose suppression test? If there is acromegaly, then after the glucose suppression test, the growth hormone level should not be suppressed. It should be high. If there is a normal individual, then after the glucose suppression, the growth hormone level will get suppressed, right? Insulin tolerance test used for, this can be used for confirmation of growth hormone deficiency, right? Then IGF-1 levels are used as a screening test for growth hormone excess, which is nothing but acromegaly. So screening test for acromegaly is IGF-1 level, confirmation test is glucose suppression test, and because growth hormone levels keep fluctuating, we do not use it as a routine investigation for either diagnosis of deficiency as well as excess, right? So guys, that's it from me today. Tomorrow we will continue with the nephrology. Whatever we have discussed today are like high yield points only, not a very exhaustive discussion of endocrine, but hopefully that would help you. Adrenal gland will be covered by surgery, and then nephro also we will focus on high yield, and we will also address some of the PYQs. So wishing you all the best guys. Stay focused. The exam is very near. So choose your preparation willfully or like tactfully. Any topic which you don't feel like, okay, I need to learn this freshly, don't waste time. I would not even recommend that you should attend my YouTube sessions on a topic which you're already familiar with. Just stick to whatever your offline classes you've attended, mine or some other teachers, or online classes, whatever. Stick to those sources. Only if you have not done the system in the past, then only I would suggest that you come to the live stream, right? So I'm signing off guys. All the best. See you tomorrow at the same time. Thank you.